So I want to invite now to talk about functional outcomes of chemoradiation of advanced laryngeal cancer, Dr. Patrick Bradley. Dr. Bradley is Emeritus Professor of Head and Neck. Dr. Bradley, please.
Thank you, and Dr. Shah, thank you for having me and being a friend for most of my working life. I'm going to talk, and I've changed the title a little, following standard conventional treatment. By that I mean total laryngectomy, radiation, and chemoradiation. And for time, hopefully, may skip a few slides, but I have no disclosures. I think it is important that we know why we make these decisions, and this slide and the next slide, I think, summarizes the current thoughts on the indications for the management of advanced laryngeal cancer. Comorbidity plays a huge part in making a decision as to what treatment you will execute. And the second, of course, is the clinic in which you attend and the relationship between the clinicians and the patients themselves. One of the problems that I see in my lifetime is we give chemotherapy, maybe with good reason, but we don't know whether it will work or not. We've never got from the bench to the bedside. I do think an attractive format for trying to solve this is induction chemotherapy, but it would appear that this has not been taken on by anybody except the French. Let's move. I do think that within advanced laryngeal cancer, there's lots, and Dr. Spiriano showed that, there's a multitude of operations. There's also a multitude of ways to give radiation and add chemotherapy or biotherapy. The problem is we're not comparing like with like. Voice and speech outcomes, and again I'm going to mainly talk about larynx and chemoradiation. It's possible with primary or secondary tracheoesophageal puncture to achieve, and I use the word satisfactory voice in about 80% of people. The problem with the laryngectomy is you've got a stoma, which I think most patients are not happy with. Equally, if you treat patients with chemoradiation, the voice will deteriorate, but generally within 12 months it has got to its level or has increased in functionality. I think it is important in the evidence here, and I'm a plugger for speech and language therapists, you do need people to encourage your patients and to advise them the whole way through their treatment, not only at the end, but during treatment. The biggest problem to me with larynx and hypopharynx, and I'll stick to larynx, is the swallowing problems. I'm beginning to think that swallowing, a normal swallow, is more important than having a normal voice. I think it is important to know that pre-treatment dysphagia does not necessarily reflect dysphagia as an ultimate outcome. The assumption, I think, as clinicians is if they have significant symptom when you start, it will probably get worse when you finish. I think surgery and radiation and chemoradiation create its own inherent problem with fibrosis, scarring, and stricture formation. But stricture formation with chemoradiation in advanced larynx is about 6%. But it is unpredictable. I think this is important as well, that while total laryngectomy seems a fairly straightforward operation, when you ask your patients following total laryngectomy, quite a lot of them have problems, but they cope with it. So you have the problem of the symptomatic patient in the early phase of recovery, and then we tend to forget about them when they are a year or 2 or 10 following their treatment. Modified barium swallow is really the gold standard for assessing swallow, but it does give you a lot more information than most patients, in fact, care about or are interested about. Therefore, this is a paper that was published recently from the northeast of England, from Newcastle. Joe Patterson, a speech and language therapist, is here, I think. I give her credit. But they found a group of patients, 123, more than 6 months disease-free following treatment. And as you can see, they had 5 different groups of patients. total laryngectomy and radiation, radiation, chemoradiation, and then chemoradiation and total laryngectomy. And they did 3 tests, and I'll show you the results: swallowing capacity, normality of diet, and the MD Anderson dysphagia inventory. I have to say, in the UK, our patients are more happy drinking beer than actually a 3-course meal. And this is a patient-orientated practical assessment of the patient's swallow. The mean swallow capacity, and I've written what the test involved: swallowing water 100 mils as quickly as was comfortably possible. And you can see along the bottom line, laryngectomy, radiation alone, chemoradiation, and chemoradiation and laryngectomy. You can see that the chemoradiated laryngectomized patient does terribly badly. The normalcy of diet, again, laryngectomized patients, radiated patients do pretty well, but chemoradiation does significantly interfere with transit time and movement of food from your oral cavity to your mid-esophagus. And then the MD Anderson dysphagia inventory. This is a quality of life, and it's interesting to show that, in fact, the patients seem to be happier in themselves, never mind about their incapacity to swallow. So in summary, long-term dysphagia is common, is a common output, and I think it is important that we know this and that our patients are treated and sympathetically looked after. Those figures were for 6 months or more following treatment. I think it would be interesting to know, to repeat these tests at 5 years and 10 years of survivors, but as we all know, a lot of these patients never live that long. There's no clear benefit of surgery or non-surgical treatment in the water swallow test, which I'm sure our Newcastle patients are very happy to understand. So what about evaluation of swallow? There's not a great deal of standardization in the literature as yet. I do think it is very important that you have a psychometric validated quality of life, because a lot of these patients get depressed, they don't have support, as was alluded to in one of the symposiums yesterday. So we really need a global indication of their functionality. Future research, like everything else, there are new aims and objectives. I think prophylactic swallowing exercises certainly does seem to help. In other words, you start pre-treatment, during treatment, and after treatment. Whether or not we should put in more or less gastrostomy tubes, the phrase in the literature is, if you don't use it, you lose it. Therefore, you do need greater intervention during their treatment, i.e. pain relief, etc. And whether or not bringing IMRT into the strategy, in other words, reduce the target volume to be more effective. This may well help. I put these 2 recent reviews up, supporting the contention that we do need speech and language therapists to see our patients before, during, and after, because clinicians, me, you, are not going to do it. And I do think these are essential people within our extended multidisciplinary care. In the UK, the speech and language therapists and the dietitians are key core members of our MDT. That's how serious we take our speech and language therapists. I think in a lot of other countries, and certainly some that I have visited, the speech and language therapist is an external referral and only works when asked. I thank you.